What we see with ketamine, as opposed to some of the other psychedelics, is that it requires a few sessions in a short period of time and then maintenance. And a lot of the other psychedelics you'll see, you took 1 to 3 doses of MDMA or psilocybin, and then they have a year of less depression, or PTSD was significantly improved. So it's a little bit of a different model with ketamine. First of all, because chronic pain has a whole host of other issues in terms of neuroinflammation that need maintenance. And second of all, they need a lot of support. And so what I find with ketamine is, even if we do the 6 sessions in a row, which is what the evidence shows, and even for chronic pain, there's moderate evidence for complex regional pain syndrome and very little for other indications. It seems like there has to be some sort of maintenance. And that's an issue in the sense that, first of all, it's not covered by insurance, and second of all, every physician has their own way of using ketamine. And I think that's also important, what patient comes to what physician and why, because the way that I use ketamine is going to be very different than a lot of other interventional pain physicians who may use 5 days in a row, 4 to 6 hour infusions with benzos, right? As opposed to maybe 2 sessions for 3 weeks, and then let's say 6 weeks later another session, then we try to spread it out to 2 months and 3 months. And the question comes up with harm reduction and addiction. Obviously I don't give prescriptions for ketamine often, and so they have to come to the office. However, and that is a form of harm reduction in the sense that, maybe they're not taking opioids anymore and they're using ketamine instead, but we do worry a little bit about a ketamine addiction going forward. So I think that what we really need is actually good clinical evidence showing that ketamine has long-term effects for chronic pain, so that we can get insurance companies to cover it. And that's something I'm working on with University of Florida now, that we're trying to make a protocol for chronic pain patients. But again, since chronic pain, there's so many indications, there's so many types of pain, then really it's a very difficult thing to study. But I just wanted to make the point that I do believe ketamine requires more maintenance than other classic psychedelics, and because of that, I think that patients sometimes feel it didn't work for them, or maybe they were doing it in a certain pattern that it could have been better, but we don't really have the evidence right now. So I look forward to seeing long-term data for ketamine for chronic pain.